Hello, and welcome to Dr. Tad Gerlinger's joint education class. We will review both hip and knee replacements in both the outpatient and inpatient surgical settings. Feel free to pause this video at any time. Class objectives include understanding why and how surgery is performed, understanding a typical hospital course, understanding a typical recovery, and discussing possible complications and how you and your surgical team can prevent these possible complications. We'll start with some knee anatomy. The knee is made up of three bones: the femur, the tibia, and the patella. In between is where we find the cartilage that provides that fluid range of motion. The ligaments that support the knee include the anterior and posterior cruciate ligaments and the medial and lateral collateral ligaments. Arthritis is the inflammation and destruction of cartilage tissue. The types of knee arthritis include osteoarthritis, rheumatoid arthritis, post-traumatic arthritis. The knee is made up of three compartments: medial, lateral, and patellofemoral compartments. If you have arthritis in only one compartment, that is what would indicate you for a partial knee replacement or a unicompartmental knee replacement. If the arthritis has spread to two or more compartments, that is what would indicate you for a total knee replacement. The surgical treatment for a partial knee replacement, Dr. Gerlinger uses a Smith & Nephew implant. He will begin by preparing the bone by removing the damaged surfaces, keeping only healthy bone. He will position the oxinium cup onto the femur, the titanium tray onto the tibia, and place a highly cross-linked polyethylene plastic liner in between. These components will be cemented in place. The surgical treatment for a total knee replacement, Dr. Gerlinger uses a Smith & Nephew implant, which is called the Legion. It is tried and true and coined as the 30-year knee. He will begin by preparing the bone by removing the damaged surfaces, keeping only healthy bone. He will position the oxinium cup onto the femur, the titanium tray onto the tibia, and place a highly cross-linked polyethylene plastic liner in between. On the back of the kneecap, he will resurface it, keeping 60 to 70% of your own bone, and place a plastic button there so there's always metal rubbing on plastic. These components will all be cemented in place. Now we'll move on to some hip anatomy. The hip is made up of the femur, the pelvis, the ball and socket joint, the femoral head being the ball and the acetabulum being the socket. The cartilage is in between this, which provides that fluid range of motion. Arthritis is the inflammation and destruction of that cartilage tissue. The types of hip arthritis include osteoarthritis, rheumatoid arthritis, post-traumatic arthritis, avascular necrosis, and congenital deformities. The surgical treatment for a total hip replacement. A stem design is selected based on a variety of considerations, including, but not limited to, the shape of your femur. With that said, Dr. Gerlinger uses total hip replacement systems by Smith & Nephew, Kyocera, and Zimmer Biomet. He starts by removing the femoral head, the ball of socket joint. He then creates a hollow center of the femur to place the metal stem. The metal stem has a press-fit indentation that allows the bone to grow into it. Occasionally, this needs to be cemented. He then places a ceramicized oxinium ball on top. After that, he will remove the damaged surfaces of the acetabulum, which is the socket of the ball and socket joint, and replaces it with a metal cup. He stabilizes it with a screw. Last, he places a plastic liner to simulate the cartilage. The most important part for a total hip recovery are the hip precautions, which include not bending greater than 90 degrees, not twisting the surgical leg inward, and not crossing the legs. These precautions are in place for 6 weeks while the bone heals. Dr. Gerlinger does minimally invasive joint surgery. The knee incision is smaller than the traditional. It's about 3 to 5 inches in length versus the 8 to 10 inches you may have seen before. The hip he does a posterior approach, no muscles are cut, and the incision is placed over the outside of the hip. It's about 4 to 6 inches in length. The benefits of minimally invasive joint surgery include less tissue disturbance, less blood loss, less post op pain, and faster recovery. There are two types of dressings and closures Dr. Gerlinger utilizes. The first being dissolvable sutures and skin glue. On top, he will place an Aquacel AG dressing. AG stands for silver, meaning it keeps the incision clean and dry. The dressing is waterproof and designed to stay in place for 1 week. You do not need to cover it in the shower. The second option would use nylon sutures and a Prevena incisional wound vac dressing. This dressing is treated the same as the Aquacel dressing. However, this bandage has a machine with tubing connected to it. It provides a vacuum seal to allow good blood flow to the surface of the skin to aid in wound healing. It is designed to stay in place for 1 week. You may shower with it, but the machine is not waterproof. We recommend either disconnecting the tubing prior to your shower or placing the machine in a Ziploc bag and placing it to the side in the shower. You will be able to remove this dressing yourself 1 week post-op. The nylon sutures will be removed at your scheduled 3-week follow-up with Dr. Gerlinger. Post-surgical dressing incision care. Both bandages are removed 7 days post-op. Please peel both dressings off like a normal bandage and dispose of it. If you have the Prevena, you will dispose of the machine as well. It is one-time use. At this point, you can leave your incision open to air as long as you keep it clean and dry. Please wash your incision gently with normal body soap like Dial and water and pat dry. You may leave open to air, or if you prefer to cover it, we recommend gauze and an ACE wrap for knees and gauze and compression shorts for hips. No tape. Do not apply any topicals like lotions, creams, or ointments until cleared by Dr. Gerlinger. And do not submerge into pools, hot tubs, or baths until cleared by Dr. Gerlinger. Please keep your incision clean and dry, and it should heal up perfectly. The type of anesthesia that's used for a knee will be a combination of a spinal regional anesthesia with twilight sedation. Twilight sedation is what's used in a colonoscopy. The hip uses an epidural with twilight sedation. We like this type of anesthesia because our patients wake up easier with less side effects like nausea and vomiting. They have better pain control and able to get up and walk faster after surgery. General anesthesia may be indicated by your anesthesiologist, and this will be discussed by the anesthesia team in the pre-op holding area prior to your surgery. Oral hydration for better results. So our joint physicians here at Midwest Orthopedics find that our patients do much better by staying well hydrated prior to surgery. What they recommend is staying well hydrated 3 days before surgery and finishing 500 milliliters of Gatorade 2 hours prior to your scheduled arrival time to the hospital. If the patient forgets to drink the Gatorade in this time frame, surgery will not be canceled. It's primarily just to aid in your success. We do want you to wash your surgical area with Hibiclens before surgery. We recommend that you wash the surgical area the night before surgery and the morning of surgery with the Hibiclens, which is also called chlorhexidine gluconate solution. This can be purchased at any local drugstore like CVS or Walgreens. Do not use the Hibiclens on your surgical incision after surgery. So the hospital and surgery center course. The patient will receive a pre-op telephone call from the surgery unit the business day before surgery to give the time of surgery, the time of scheduled arrival, and when to stop eating and drinking. On the day of surgery, the patient is to report to their scheduled facility for surgery. Rush University Medical Center is the only facility that is inpatient surgery. So these patients are required to stay at least 1 night in the hospital. Oak Brook, Gold Coast and Munster are all outpatient surgery centers, and the patient will be discharged home the same day of surgery. The patient should expect to be in the pre op holding area for 1.5 to 2 hours before surgery. Family is welcome in the pre op holding area with you. This is where you'll be prepped for surgery and meet with your anesthesia and surgical teams. We expect you to be in the operating room for about an hour and a half to 2 hours. This will consist of administering anesthesia, positioning, opening, implanting, closing, and reversing anesthesia. Dr. Gerlinger's portion is only about 30 minutes. You will then be brought to the recovery room where you'll wake up from anesthesia. This typically takes about an hour. If you are at Rush, you will then be transferred to the orthopedic floor, which is on our 13 East Tower. If you're at the surgery center, this is your last stop before discharge. The types of lines, tubes, and drains you will receive include a peripheral IV. This is where you will get all of your fluids and medications during surgery. This is the last thing to be removed prior to leaving the hospital. You will also be given a sequential compression device, otherwise known as an SCD boot or massaging boot. This will help circulate your blood flow during surgery to decrease the risk of blood clots. And then hemovacs will be applied to total knee replacements only. This will help decrease the pressure on the incision. There are a few discharge requirements. Prior to discharge, you will have a few tests to pass. You will meet with a physical therapist where they will fit you for an assistive device like a walker or crutches. They will walk you around the unit and clear you on stairs and teach you a few exercises that you can do at your first week at home. The medical team will also clear you, making sure your vitals and lab work are within normal limits prior to discharge. We will also make sure your pain is managed appropriately prior to leaving our facilities. Cold therapy after surgery is very important. We will give you a gel ice wrap that consists of 2 gel ice bags. These gel ice bags are good for about 4 hours. We recommend icing 4 to 5 times a day for the first few weeks. Icing is a part of both pain and swelling therapy. If you are interested in purchasing an ice machine, you may do so at one of our DME medical stores here at Midwest Orthopedics. Now we'll go over your typical postoperative pain management regimen. So this regimen was created by our pain anesthesiologists and ortho joint surgeons here at Midwest Orthopedics. What they created was a multimodal schedule. Multimodal, meaning that each pain medication at its lowest dose blocks a different pain pathway in the body. And then they created this schedule so that you stay around the clock with or without pain. You're taking this to stay ahead of the pain. So we'll start at the top here. The gabapentin acts on nerve pain. It's taken 3 times a day or every 8 hours, and it's only prescribed for 2 weeks. Then you have Tylenol, which is over-the-counter extra strength Tylenol for pain management. This is taken 3 times a day, which works well with the tramadol. The tramadol is a mild narcotic, and this can be taken 3 times a day. You may combine these first 3 medications. Just be sure that you eat something before taking these. The meloxicam is an anti-inflammatory. This is going to help with swelling. It's taken once a day after a meal, and it's prescribed for 1 month. The oxycodone is prescribed for breakthrough pain, which means that the rest of the pain medications are not covering your pain appropriately. This is when you would take the oxycodone. You can take 1 tablet every 4 to 6 hours as needed for breakthrough pain. We would recommend spacing this out from the tramadol at least 1 hour to avoid the same side effects. Oxycodone can be prescribed up to 3 weeks post-op, and the tramadol can be prescribed up to 6 weeks post-op. Please contact our office should you need refills of either of these medications. You will be prescribed a blood thinner to help prevent blood clots after surgery. Typically, our patients receive an aspirin, so baby aspirin, twice a day for 30 days, unless indicated differently by a hematologist or a cardiologist. We will prescribe a stool softener, which will help the constipation that typically can happen from taking any sort of narcotics or opioids. So we will prescribe this then to your pharmacy. For our outpatient surgery center patients, you will receive an oral antibiotic to take for 10 days and an anti nausea medication that can be taken as needed. Physical therapy after surgery. Midwest Orthopedics at Rush has an outpatient physical therapy in the home program. This means a Midwest Orthopedics at Rush physical therapist will come to your home for physical therapy following your joint replacement surgery with Dr. Gerlinger. Dr. Gerlinger recommends that your first visit be approximately 5 to 10 days after your surgery. You will be contacted by a member of our in home program approximately 2 weeks prior to your surgery to schedule the home visits. Our in home program should last about 1 to 3 weeks after surgery, and you should be transitioned to an outpatient physical therapy clinic by week 3. Your therapist will work to transition you to this clinic. Dr. Gerlinger strongly recommends outpatient physical therapy at a Midwest Orthopedics at Rush location. Please research outpatient physical therapy locations at an outside organization if you prefer to go elsewhere or Midwest Orthopedics is just not a convenient location for you. If you live outside of Illinois, please begin your outpatient physical therapy 5 to 10 days post surgery. Patients can opt out of this in home program and choose to begin outpatient physical therapy in the clinic immediately, which would be 5 to 10 days post op. It would be your responsibility to schedule these outpatient visits. Follow-up visits in the office include a 3-week post-op check. This is where your incision will be checked. X-rays will be getting for We will get X-rays for all of our knee patients and nylon sutures will be removed. 6 weeks post-op, X-rays for both hips and knees, and then clearance to resume normal activities. We will see you annually and as needed, and telemedicine visits can be available upon request. You may do these visits with our nurse practitioner, Alyssa Winter. She's also located at our Midwest Orthopedic locations, and she does post-op follow-up appointments, hip and knee evaluations, and knee injections. You may schedule with Dr. Gerlinger's office with Alyssa, and she also does telemedicine visits. Common questions we get. So when can I return to work? So if you have a light duty desk job, typically 2 to 4 weeks post-op is appropriate. If you have a heavy duty active job, 6 to 8 weeks post-op would probably be better for you. If you do provide us with FMLA paperwork, we will write you off for the full 12 weeks and you can return back to work when you feel ready to do so. As far as driving, you can start driving at about 2 weeks post-op as long as you're off of the narcotic pain medication and feel safe behind the wheel. Dr. Grillinger has performed research studies showing that your brake reflex comes back about 2 weeks after your surgery. As far as flying, we prefer to see you at the 3-week post-op appointment before any flights. They don't do implant cards anymore. All you have to do is let the TSA agent know that you have a metal implant and opt to go through the scanner where you put your arms above your head. As far as returning back to normal activities and exercising, we will typically clear you for this at around 6 weeks post-op. At 6 weeks post-op, we believe you're about 75% recovered. You'll reach 100% at the 6 month to 1 year mark. We would want you to ease into activities after that 6 week mark. And if you are planning on having another hip or knee replaced, there is a minimum of 6 weeks between surgeries, sometimes 3 months, depending on your insurance. So, potential risks and complications, everyone's favorite topic. Infection is a risk following a joint replacement. However, with Dr. Grillinger, it is less than 1%. That is because we do a lot to avoid infection. First, we make sure you're medically optimized by a rush internist to rule out any potential infection risks. We recommend you wash the surgical area with Hibiclens the night before surgery and the morning of to remove any bacteria on the surface of the skin. This can be purchased over the counter at any local drugstore like Walgreens or CVS. You will be given a full course of IV antibiotics at the hospital and a private room, so no pesky neighbors coughing or sneezing near you. We do encourage short hospital stays to avoid hospital acquired infections and create floor goals to discharge you safely and effectively. And most importantly, we put our dental prophylaxis in place. Dr. Grillinger recommends no dental cleanings or dental work to be done 3 weeks before surgery or 3 months after surgery to avoid infection. This is because bacteria builds up in the mouth, and when the dentist is poking in there, they can create entryways for the bacteria to enter the bloodstream in which they like to colonize onto artificial implants, including hips and knees. Therefore, Dr. Gerlinger has a lifelong recommendation to take an oral antibiotic 1 hour before any dental appointment to avoid this infection. Blood clots are another risk, including deep vein thrombosis and pulmonary embolisms. We will teach you what to look for and also put you on a blood thinner and get you up walking soon after surgery to promote good blood flow. Hematomas are a blood accumulation in the joint space. Dr. Grillinger will place a surgical compression dressing on your site to avoid this. Hemovac drains will be placed in total knee replacements and will be removed prior to discharge. You are at risk for loosening or failure of an implant if you do too much too soon. You can't heal yourself faster, and it will be important that you take it easy and give your body proper recovery time to avoid significant issues. Low impact exercises like walking, biking, hiking, swimming, dancing, elliptical are recommended with your new joint once healed. High impact activities like jumping, running, tennis, pickleball, and hockey can typically begin around the 3 month mark when seen by Dr. Grillinger. You are at risk for residual pain and stiffness and for any fractures with falls. So please always notify the office with any falls. You're at risk for nerve injury with any lower extremity orthopedic surgery, including perineal nerve damage or foot drop. There is an increased risk for perineal nerve injury with preoperative valgus knock-knee deformity. Blood loss in surgery is very minimal. Dr. Grillinger loses 2 to 3 small medicine cups of blood. This is why we do not have you donate blood before surgery, as you put yourself at more postoperative risk with blood depletion. We will give you blood if indicated in surgery, however, it is very rare. Potential skin issues include skin tears, blisters, delayed wound healing. Sometimes the adhesive from the bandage can cause blister formation or skin tears. The potential for tears depends on the patient's skin integrity. Some patients are at risk for delayed wound healing depending on their health. Some patients report a clicking sensation after surgery. There is now plastic and metal rubbing on each other, which can cause this, but also swelling can cause this sensation as well. Once the inflammation goes down, this should fade away. Leg length discrepancy can sometimes be noticed when the surgical leg feels longer than the non-operative leg. During surgery, Dr. Grillinger corrects the angle of deformity and makes you straight. This will make you feel longer or taller, but the sensation comes out when the patient has worn out the joint, causing alignment issues. Dr. Gerlinger does not make you taller, but he does make you straight. This will feel normal after proper gait training and stretching out the ligaments and muscles over the next couple of weeks to months. Insomnia can be present after surgery as well. If you're having trouble sleeping at night, Dr. Gerlinger recommends not taking naps during the day, avoiding caffeine, icing the joint down 30 to 60 minutes before sleep, limiting activities after 4 p.m., and replacing your Tylenol dose at night with Tylenol PM or including melatonin. Symptoms after surgery. So some common symptoms would include significant swelling and bruising throughout the surgical leg. We do expect the surgical leg to get twice the size of your non-surgical swelling and bruising from the hips down to the toes. Sometimes patients can notice some low-grade temperatures, less than 101.5, a little bit of redness and warmth a couple days after surgery, as the body's inflammatory response peaks and the body responds to surgery. This would be normal. When to call would be if you're experiencing any calf tenderness, swelling, or redness. This could be a blood clot, and we would need to know about that. If you do start to experience high fevers, more than 101.5, total body chills, significant drainage, pus, foul smells, spreading redness, things that look or smell funny, please always call us. Or if your pain is uncontrolled with the medications we prescribe, please give us a call so we can adjust this. We would recommend that you sign up for Dr. Grillinger surgery texts. We have received a lot of great feedback from patients regarding these texts. All you have to do is before surgery, text join to this number and follow the prompts to enroll, and you'll get some helpful tips and tricks to help you in your preparation and recovery for surgery. There's also an optional nutrition package available for purchase. It's called EMN Orthopedic Nutrition Bundle that can be purchased at our DME store or on this website. It helps support lean muscle mass and wound healing. It's protein supplementation. It is not a meal replacement, but if you feel you do not get enough protein in your diet, this would be a good option for you. It's designed for 2 weeks before surgery and 2 weeks after. And the two flavors they offer are vanilla bean and decaf cold brew. So, what do you do now? How do you prepare for surgery? So, stop the medications as directed by your rush internist. Prepare your living arrangements at home as necessary. Move rugs out of the way or tables to avoid any falls. Sign up for those surgical techs, they do help. Start the protein supplement if you opt to do that. Wash the surgical area with Hibiclens. Stay well hydrated and eat nutritious meals. Relax and know that you are in great hands. Thank you so much for taking the time to review this class. We look forward to taking care of you. Please reach out with any questions. This is our main office line, and it called for anything, and we will be seeing you soon. Thank you. Bye bye.